Okay. All right. Well, thanks again to the organizers for inviting me. Some of the things that Dr. Gelbach spoke about are pretty near and dear to me. I just returned from that oral board subspecialization process in Dallas, and it's quite stressful and not very much fun.
But you passed.
I passed. So, and he's right, it has one of the lowest pass rates of all of the medical subspecialties in the United States, so it's quite arduous. But let's get started. I've been tasked with hopefully teaching you everything you need to know about infertility in about 30 minutes. So that's 10 years of information in 30 minutes. So I'm going to give you a little bit of medical information, and the goal of the talk really is for everyone to be empowered to be able to take charge and optimize their outcomes for their fertility care. So there's a little bit of medical information. To me, this is very informal, so if you guys have questions, feel free to raise your hand and stop me right in the middle of the talk. And then several of you submitted questions that Tammy or Allison sent to us, and I've got those stacked at the end, and I'll try to leave time for some questions for the group, okay? All right. So first things are our definitions. And basically, if you're trying to get pregnant for a year and you don't succeed, then you have infertility. And if you're not using birth control, that counts. So you don't have to be quote-unquote trying. So if you're not using birth control and you're in the same zip code and you're having intercourse for a year and you're not pregnant, you have infertility. You don't have to be quote-unquote trying, which is something I talk to patients about a lot. I won't read these, but there are some obvious cases where you may want to come see us earlier, and they just really speak to specific obvious etiologies or causes for infertility. So if you think you have one of these things or one of these problems, you may want to contact us or your OBGYN and see if referral or evaluation is important. About 40% of the time, infertility is a female issue, and about 40% of the time it's a male issue, and about 1 in 3 to 20% of the time it's quote-unquote unexplained. There's also a large group of patients that we see in our practice, and I'm sure Dr. Milroy, Dr. Gelbach, and the other physicians do too, who have more than one problem. So it's not really uncommon to see someone who has a sperm issue or a quote-unquote a male factor issue and also a female issue. And we really see that in about 1 in 3 of our patients. So that makes things a little bit more challenging. So it's possible to have multiple causes. If you look at it just from the female perspective, you got about 40% of the time some ovarian issues, 40% of the time tubal or pelvic disease, and then there's this unexplained group and other causes that we won't talk about today because it's not really going to be relevant to most people. And we're going to talk about each of these as we move through the slides. This is kind of a list of common causes. I'm not going to read them to you. You've got them in your packet. So just kind of review those. Everything from the male causes to tubal disease to egg quality to endocrine disorders. Now, you saw some of these pictures in the talk from, or in the piece from Larry on the TV. Basically, these are ingredients you need to make a baby. I try to keep things simple. So you need an egg. Everybody knows that. You need a sperm. You need a sperm and egg to fertilize. And then you need what I call a good house. And you need a highway. You need the tubes to be open so the egg and sperm can get together. All right, so all of our initial evaluation that Dr. Gelbach was talking about, that comprehensive evaluation, really focuses on these primary issues. And we're going to talk about each of these, but just keep these in your mind: egg, sperm, fertilization, highway, and house. All right, now it takes 2 to tango. So we'll start with talking about how the egg and the sperm can get together. So just a picture, there's some questions at the end about endometriosis. Someone submitted some questions, and this is kind of a cartoon of what endometriosis looks like. You can see these little areas of what we call induration or scar tissue formation. And you guys see these little things that look like spider webs? Those are not normal. They shouldn't be there. That is scar tissue caused by inflammation from endometriosis. And the fallopian tubes need to be free and mobile. And that means they can walk over to the ovary and pick up an egg. Now you can imagine if you limited their ability to pick up the egg, either by constricting, see these little fimbria right there? They look like little tentacles from a sea anemone. See how they're stuck down over here? That's not normal. So that's how endometriosis or scar tissue formation can cause infertility. And this is a real picture. Do you see this little black spot there? Can everybody see that? So that's a piece of endometriosis that's adhered and stuck down into the peritoneum. You see how it's white and glistening and looks like it's starting to pull things together? That's the beginning of scar tissue formation. So endometriosis and or scar tissue formation can cause infertility. And you can get scar tissue from surgery, you can get scar tissue from infection. There are other cases, but one common cause is endometriosis. Now, if you don't make an egg available to the sperm, that's a problem as well. So most women ovulate normally, but some don't. If you don't have regular periods, that's a pretty good sign that you may not be ovulating normally. Pretty good evidence. One example of this that we see a lot is polycystic ovary syndrome. Now, these are trapped eggs down here. This is a normal ovary. See these couple little eggs here? But see how this one is filled with little eggs? So they're just trapped eggs that haven't been able to get out, haven't made themselves available to the sperm. And that's why you see poly means many and cyst just means little fluid-filled cysts. So polycystic ovary syndrome is another example of why the egg and the sperm can't get together. I'm going to focus on something that is kind of near and dear to me. I've published several articles on anti-Mullerian hormone in the literature, but we're going to talk about eggs. And there's a question at the end from someone in the audience about egg quality, and they said, how important is age? It's extremely important. It's almost always the most significant factor. It's almost always, I shouldn't say, it's almost always a significant limiting factor. So age matters a lot. When you look at all of these different labs that we order, like FSH and anti-Mullerian hormone, and we'll talk about these more, age is almost always the most predictive of pregnancy. And it's also predictive of miscarriage rates as well. And we'll talk about why that is. So how common is this? It's extremely common. 1 in 6 women, if you walk by 5 women on the street between the ages of 15 to 44, you just pass another person who has infertility, or you're very likely. So it's quite common. I like to show this slide. It looks complicated. Here's what I just want to show you. Here's age. Here's just pregnancy rate. And look at this. 50% of women by age 31 have some fertility issues. Right? And by 41, 50% of women are sterile or infertile. And that's why age matters. All right? But look what this is interesting too. By 46, 50% of women start to have menstrual changes. They start to go into menopause. But here's an important point. They started to become infertile about 15 years earlier. So by the time you're experiencing hot flashes, by the time you're experiencing changes in your period, you're probably infertile. So that's an important point to remember. And then, of course, menopause, commonly about 51 in the United States. It's a nice slide to kind of hopefully make things a little bit lighter after that somewhat depressing slide. I like to have children, but I want to have a career first. And that's what we see. And this is common. And this is how common it is. This is CDC data and census data from the United States. The red here is kind of where you start experiencing infertility. Look what happened over the last few years. Pregnancy rates dropped dramatically in teenage ladies. That's great. That's fabulous. We spent millions of dollars. Still dropping in younger women. And look what happens here. 45 to 49-year-old women, 150% increase. I know some of those women are very infertile. Now, some of these are egg donor women, most of them. And the sheer volume of women trying to get pregnant is increasing those numbers. And this means I think that we're doing a pretty good job. We're getting a lot more people pregnant. Right? So women are trying to have children later, and that's when they're at the greatest risk for having egg quality problems. You say, why does this happen? Well, it's a terrible system. And we didn't design it. But here's you ladies in your mom's belly, 20 weeks old. That's your maximum number of eggs. Right here. By the time you were born, look how many eggs you lost. All right? And this is a blow up of 18 to 48. So there's nothing you can do about this, unfortunately. This is biology, and it just happens as time goes on, and there's nothing that you did or didn't do. You can't prevent it. Maybe you can. If you can, call me. I want to patent it. But it's important. People lose eggs at different rates, and that's a genetic issue. If someone operates on your ovary, perhaps, or there are some other causes. But for the vast majority of women, they're taking good care of themselves, they're being healthy, they're not smoking. It's genetic. So that's why we do see some patients in their 30s, as the slide alluded to. And this is a similar slide. Look what it's just showing you. As women age, this is basically what you're looking at here is number of eggs declining. And this is also quality of the eggs. And the quality of the eggs declines as well. Or put a different way, if you take a perfect, 25-year-old woman and man, there's no perfect man, but they have perfect sperm, they have sex at the perfect time, you're looking at about a 15 to 20% per month rate of pregnancy. That's the ceiling, ladies and gentlemen. That is it. By the time you're 30, you start to see some subtle declines, about 9% per month. Okay? And then when you get out here in your upper 40s or mid 40s, it's not very high. So we see this in real life data. This is SART data, Society for Assisted Reproductive Technology and Center for Disease Control data in the United States. Some of my patients are in the room. They probably have seen this chart before. This is the whole country, 2006. And look what happens. These are IVF cycles, live birth rates. And right when you get about 35, you start to see that slope of the curve decline, and you start to get declines in pregnancy rates. Now, interestingly, you might wonder what this line is. And it's just instructive. These are donor eggs. So if you're 48 years old, your donor egg rate is, in 2006, 55%. And what that's telling you is it's all about the egg. All right. Now, we're going to talk a little bit about testing for ovarian reserve. And there are a lot of factors. Ovarian reserve is just egg quality and egg quantity. All right? So what matters? I made age a big box. I said age is a big deal, and it is. But we also look at these different labs. Genetics is a big box. Lifestyle matters. If you smoke, that's going to contribute to early menopause and some depletion of eggs. And then things that may or may not have happened to you. If someone removed an ovary or cut out part of your ovary, that could play a role. All right, now what about problems with the home, the uterus? We talked about this a little bit. You got to have a highway, fallopian tubes. These are fibroids. Anybody heard about fibroids? So fibroids can be a problem just because they interfere with where the embryo or the little baby wants to implant. And where they are matters a lot. We won't talk about that. You can also get polyps. But anything that interferes with the ability of the egg and the sperm to get together, or the embryo or the little baby to implant, can cause problems. Now, what's in the basic evaluation? Remember the original slide, egg, sperm, fertilization, and then home. Well, you're going to look at the sperm, because we said 40% of the time the male plays a role. You're going to ask the patient if you have regular periods. It's the cheapest, best test ever. Right? Just real simple. If you're having periods, you're probably ovulating. It's about 99% correlation. We're going to look at egg quality, and you'll look at egg quality a number of different ways. We're going to look at the tubes, the ovary, and the female anatomy. A little bit about a semen analysis. Back in the day, before I was doing this, I used to count them manually. You'd take the sperm, and you wouldn't count every sperm, but you'd count a number of these. Can you see these little squares? You'd extrapolate that out. Now most of us use computers and then extrapolate it out. But we don't look at every single sperm in a 300 million sperm sample. All right? I talk about this a lot with my patients because the gentlemen get quite upset. Not all sperm are normal. It's normal for most sperm to be abnormally shaped. I'm going to say that again. It's normal, gentlemen, for most sperm to be abnormally shaped, so don't get your feelings hurt. Here are some different shapes: big sperm, little sperm. I made this up, but I call that the platypus sperm. But you can see there are a lot of different shapes. Normal sperm tend to link up with the egg best. Okay? So it does matter how they look. That affects the binding of the egg and the sperm. And also, we see a lot of variability in sperm. I'm not sure if this gentleman was paid or not, but he provided a sperm sample every couple weeks for 120 weeks. And look at the variability and the concentration in the sperm. So there is quite a bit of variability. So if you have a semen analysis, guys and ladies, it's not going to be the same twice, and that's normal. All right, so I just want to point that out to keep your anxiety low. Now, how do we look at egg quality? I don't know if you guys can kind of see this, but this top ovary, it's very small, it's compacted down, and that's an ovary that has egg quality or ovarian reserve issues. The bottom ovary, I don't know if you can see it, but there's lots of of little follicles or eggs sitting around the periphery, and it's larger. That's more of a normal ovary. So ultrasound is one of the ways we look at that. We call that an antral follicle count, or AFC. You can look at hormones. You can look at history. That's very important. Prior performance in an IVF cycle is the best predictor of future performance. The problem is you don't want to fail a cycle to find out you're going to do bad. You'd like to know in advance, right? And so that's what all these other measures are designed to do. They're designed to help us as physicians help you understand what your chances are, which is really important. All right, so have anybody heard about FSH, follicle stimulating hormone? Well, FSH is one of the labs that we look at. It's been around forever. It was kind of discovered where I trained at the Jones Institute, where we had the first IVF baby in the United States in the 80s. But as FSH values increase, pregnancy rates drop. And this is a study by Richard Scott, who's up in New Jersey. He looked at about 9,000 women. And I'm just pointing out, see how the FSH values increase? These are birth rates. And above 18, your pregnancy rate's very low. In this study, if your FSH is above 18, it was 0 in 9,000 women. Now, I've since talked to Richard, and he's got a few people pregnant with FSHs higher than 18, but it's going to be tough. Okay? And then you got to stratify by age. You can see that an FSH of maybe 12 in a 43-year-old has a pregnancy rate of 0. In a 35-year-old, it might have a pregnancy rate of 40%. So age matters a lot. Going back to the question, does age matter? It matters a lot. All right? But you always have people that break the rules. See here? There's several years of FSH values of no pregnancy. And then look, they had a patient who was 43 who had an FSH of about 16 who got pregnant. There's always exceptions. None of these tests mean you absolutely cannot get pregnant. They're just tools to help guide us about what your chances are. Okay? Does that make sense? Can't emphasize that enough. All right, now we look at the uterus and tubes. This is pictures of a hysterosalpingogram up top. I'll tell you what that is. Some of you in the audience have had that, I'm sure. We put a little dye in the uterus. We'll look at this white part here, and you see different designs there, basically. Now, sometimes this hurts, so I want to emphasize why we do it. This is a septum here. You see that? See that thing that looks like a little bit of an upside-down mountaintop there? That's not normal. That's right where the baby would want to go. So you want to find that out. You got bunny ears over here, as I call it. That's an abnormally shaped uterus, and you've got scar tissue here. So one purpose is to look at the uterus and see if there's anything going on inside. Okay? Everybody understand that? Got it? Okay. All right. The other important thing is we want to look at your tubes. And here you can see the white dye coming in. It's really clear, but on x-ray it looks white. And you see the dye spilling out into the right and left. See the right tube and left tube? So this is normal. This is a slide I got from a friend of mine in Chicago. This is a very abnormal HSG. This is a big fibroid. And you can see the dye spilling out along the edge of the fibroid. And here's the tube. See the tube coming up over here? So that's why this test is useful. That's why this test is normal. This can be done surgically. You can undergo a laparoscopy or a hysteroscopy, but that tends to be a bigger deal. So most of the time we do an HSG because it's actually easier and safer. All right, now what about treatments? Treatments vary with diagnosis. That's really important. So there's some questions at the end, and I want to emphasize, I'm going to answer them, of course, but all your care needs to be individualized to your specific situation. So if my answer doesn't jive with what your doctor's doing, it doesn't mean that your doctor's wrong. It means that your situation may warrant a slightly different approach. So it needs to be individualized. Cookie cutter medicine is terrible medicine. It needs to be individualized to your specific situation. So there's some simple, more inexpensive treatments and some more complex treatments. You want to know, what's my chances here? I try to always be thinking in a ratio. What's your pregnancy rate relative to the cost? So if your pregnancy rate is like 0.5% and it's a cheaper treatment, say it's an IUI and it's $900, that may not be good because it's a very low pregnancy rate. So you want to look at not just what does it cost, but also what is that getting you? What are your chances of pregnancy? All right, and that's sometimes more expensive is actually cheaper. Okay, this is a slide. These are general numbers. I usually show this to my patients. If you're fertile, remember there's that perfect 15% or so per month. If you've been trying for a year, you got 1 or 2% per month on your own. You can still get pregnant. You can do IVF and not get pregnant, guys, and you can come back in 8 months and get pregnant on your own. It's always possible, unless you have no tubes or no ovaries or no sperm. Those are situations where that would be true. Then you can do inseminations, you can do pills. You're going to get you somewhere around 9 to 12% per month. You can add injectable medicines in, and then IVF is going to get you somewhere around 60%. I'm going to talk about these individually, but it's important to kind of understand these relative numbers. What about pills? How do you do it? You take a pill for 5 days. We do an ultrasound. See that little black spot there? That's an egg. So we want to make sure an egg develops. All right? And these are some of the things that Dr. Gelbach was talking about. Most OBGYNs are great, but they don't usually manage these cycles with ultrasound. And that's important because some women will take this medicine and they won't make an egg. So you want to know that, because then you may need a different dose or a different treatment. Take the sperm, purify and concentrate it here. See, there's a lot of cellular debris here, and this looks nice, and these are beautiful sperm. These are what I call the Navy SEAL sperm, best swimmers. All right, so we can put them up inside the uterus, release them right here. Look at what we've done. We know you made an egg. We know you ovulated an egg because we gave you medicine to ovulate. We know your tube is open because we did the hysterosalpingogram, and we know we got a lot of good guys up there to try to help you get pregnant. And that's the whole purpose, to be able to try to manage all of the variables to give you the best chance. The rest is in God's hands. All right? We talked a little bit about this. It's good for ovulatory dysfunction, unexplained infertility, mild male factor, not severe male factor. We'll talk about why. Pregnancy rates we talked about. IUI is helpful. You want to move on after 3 to 4 cycles, and I'll explain to you why that is. I occasionally get patients who've done 10, 11, 12 cycles of Clomid. You're probably, in my humble opinion, should be moving on well before that, and I'll explain to you why. You can add injectable medicines. Slightly higher pregnancy rate. Usually people will combine that with IUI. The big risk here, and I can't emphasize this enough, is multiple pregnancies. I want to say something that's really important to me. Dr. Gelbach talked about the septuplets. John and Kate plus 8, which is now Kate plus 8, were from injectable medicines, not IVF. IVF is a treatment to minimize your risk of multiples. If every woman and gentleman, every couple could do IVF, we would help our nurseries out tremendously. All right? So I want to be clear on that. There is a higher pregnancy rate, slightly, but a significantly higher multiple rate. So you'll be very, very careful about that. All right? How does this work? You take the shots for a few days. You take the medicine to make you ovulate. You do the IUI or insemination, and you check a pregnancy test. You say, how many times do I do this? Most of the time, statistically, people will be pregnant in the first 3 to 6 cycles. We usually tell people or talk with people about moving on after 3 or 4 tries of one type. Okay? So maybe 3 or 4 tries of pills, and then if you may move on to IVF, or 3 to 4 tries of injectables. And you just see these are cumulative pregnancy rates. It's a very old slide that I got from Dr. Bravak. But bottom line is the vast majority of people, look at this slope, it's a tremendous, so a lot more people are getting pregnant in cycle 2 than cycle 1, but see how that line gets kind of flatter? That's because not very many people are getting pregnant in the 4th, 5th, and 6th cycles. So you can still get pregnant. It's just your return on investment, how much you're paying emotionally and financially is lower, significantly so. And I don't really recommend anybody do more than 6 tries. All right? Because at that point, you may have just as high a pregnancy rate trying on at home, and that's cheaper and more fun. All right? A little bit of basic information for you about what happens. You don't need to look at these. This is just embryology stuff. Egg comes out of the ovary, fertilizes in the fallopian tube, and grows and develops. It looks like this on day 5. This is called a blastocyst. Some of you have done IVF. We do primarily blastocyst transfers. We return on day 5. Why do we do that? Well, because that's what happens normally under physiologic circumstances. All right? So a little bit of information about the eggs. Know your risks. You don't want to end up with this. All right? Because this is a pretty picture, but quadruplets, triplets have 17 times the increased rate of cerebral palsy. And it's very serious, and it's a lifelong situation, so you want to be very careful about that, especially if you're a young lady doing injectable medicines, because age is on your side in that case, right? We talked about that. All right, what about IVF? When do I have to be done, ladies? Oh, we got lots of time.
Questions, though.
With everything.
With the questions.
With the questions.
Got it. Yep. Okay. We'll spend 5 minutes talking about IVF, and then we'll do questions. So with IVF, you want to know what are the pregnancy rates, what are the multiple rates, and it treats almost all causes. And it might be your first stop. Okay? Now, I think traditionally, perhaps back in the 80s, when the first IVF babies were made, when Howard Jones at the Jones Institute, where I trained, conceived the first IVF baby, it was nobody's first choice. It was a different time then. Pregnancy rates were terrible. But they've come a long way, and those pioneers were, accomplished all that. What I'm trying to say is 1% of all babies in the United States are born from IVF today, right now. Probably slightly higher. That data was from a couple years ago. 5% of all babies in Europe are from IVF. So 5 out of 100 babies. So if your physician says IVF may be the right first option for you, that may be the case. So it sounds perhaps very aggressive, perhaps over the top, but it may be the right treatment. It may be slightly more costly, but it may get you a baby and you're off to the races very quickly. And it's not the right treatment. It's not the first right treatment for everybody. That goes back to individualizing care. All right. Well, let's see. I thought I had a slide here. Apparently it is here. But in IVF, what we do, to kind of summarize, is give you medications to stimulate the ovaries to make lots of eggs. It's the same fertility medicine that we were talking about before, the shots. Okay? Then you undergo about a 15-minute procedure. And it is a procedure. There's usually anesthesia associated with it. That's so you're not mad at us, because it's a little bit uncomfortable for you to be awake. And we remove the eggs. We take the eggs into our laboratory and combine them with the sperm. We grow them in the lab for either 3 or 5 days, and then return them back to their rightful owners. Okay? Here's the big benefit. In that circumstance, we're controlling how many embryos to return back into the uterus. Okay? If you're doing injectable medicines like John and Kate did, you can't control how many embryos tango with how many sperm, or correction, how many eggs tango with how many sperm. Does that make sense? So every once in a while, lightning strikes, and you've got 4 eggs and all 4 fertilize, all 4 implant, and all 4 make it. And that's how you get quadruplets. In IVF, it's just the opposite. We want to get as many eggs as we safely can to optimize your pregnancy rate. And then take those eggs, fertilize them with the sperm, return usually 1 or 2, okay, which is going to get your pregnancy rate of about 60%, maybe 55%, and that varies by age. And then if you have extra embryos, you get to freeze them. And you can thaw those embryos out and use them for a little brother or little sister. Okay? So that offers you a lot of power. And I would say that multiple rates in IVF are not 0. Even if we put 1 embryo back, about a 1% rate of twins. You can get identical twins because the embryo can split. But that we can't do anything about. All right? So here's what you want to know, I think. What's our cause? What's going on? And your doctor may not know the first day, in fairness. Some of these tests will help them decide. Okay? How will the treatment address the cause? How does it work? What are my chances per try? How many cycles should we do? This is an important one of my pet peeves. What are my chances for multiples? And when I talk about twins, and I do it with almost every single patient, some of my patients tell me that twins are double coupons. That's like double the benefit. So there's actually been some studies written that having twins one time may be about as safe as having 2 singleton pregnancies, but I would just say our goal is generally for you to have as many babies as you want, 1 at a time. So that's the safest way, in my opinion. And then, are there any alternative treatment options? And to summarize, I would just say the best treatment is the most conservative treatment, i.e. the one that interferes the least with your life, that costs you the least amount of money, that gets you pregnant the fastest. Sometimes that's IVF, sometimes that's injectable medicine, sometimes that's pills. And I should say sometimes that's egg donation or sperm donation, right? So you want to maximize your pregnancy rate and minimize your multiple pregnancy rate. All right, this is our great team, lots of experience here. I'm here, my successes are primarily a function of their hard work. Questions? I think we can finish early and take some questions from the audience. What do you suggest when someone suffers? This is not in there, ladies and gentlemen. I apologize. That was not in the, but you certainly can write these down or get with me afterwards. I'll give you a copy. Someone wanted to know, what's the evaluation for recurrent pregnancy loss? This is quite complicated, just because the data for recurrent pregnancy loss is relatively poor. I just got back from a conference in Washington, D.C., and the speaker was from Boston. And she was from Stanford. And she was giving the talk on recurrent pregnancy loss, and the guy who organized the talk said, she said, Dr. Scott told me only to talk about evidence-based information in recurrent pregnancy loss. So therefore, this talk is going to be very short. So there's not a lot of good information, but I'm going to give you what we know. About 20 to 30% of causes of recurrent pregnancy loss are anatomical. You guys remember we saw that septum or that mountain growing down from that uterus or the bicornuate uterus? So you want to get an HSG. I think that's a good evidence-based way for testing. You want to look at endocrine causes. So thyroid evaluation, if you're at risk for diabetes, things like that. There's something called antiphospholipid syndrome, so we usually will get some laboratory studies that look for that. Some people will evaluate you for hematologic abnormalities or some blood clotting disorders, although that's slightly more controversial. And sometimes we'll get a karyotype, a chromosome evaluation of mom and dad. It's quite possible for all of us, including me, to have a hidden genetic problem and to look and feel and be totally normal and to be transmitting that, and that can be causing pregnancy loss. And that's actually treatable with IVF. And what we didn't talk about are pre-implantation genetic diagnostic testing. So in summary, I think, of course, a good history and physical, that always goes without saying. Treatment of anatomical causes, some lab studies for antiphospholipid syndrome testing, possibly some studies for hematologic or blood clotting abnormalities, and possibly karyotype evaluation or looking at your chromosomes. All right? So the second question was, can you address new technology for freezing and thawing embryos? Well, I think this refers to what we call embryo vitrification. So, you know, IVF stands for in vitro fertilization. The vitro part stands for glass. That means in glass. I think that was, in fact, I know that was because we used to put all the eggs in test tubes and they were made of glass. It's not really true anymore. They're made of plastic. But vitrification also means in glass. And that's rapid freezing of eggs or embryos. And it's thought to potentially produce better outcomes or pregnancy rates, although I would say that's controversial. At our center, we have not vitrified embryos because our thaw rates are very high. We have about a 90% thaw survival rate in our embryos. That's relatively successful, so we haven't changed it because it's not broken. Now, we just this week received permission to begin freezing of eggs, which is a totally different creature. Not embryos, but eggs. And when you have an egg, you have to do vitrification because it's one large big cell. So I guess I would summarize that question by saying some centers do this process of vitrification on embryos and certainly on eggs. And the really important point is, what is their survival data and what's their pregnancy rate data? If their pregnancy rate data is great and their survival rate data is great, you don't care how they thaw their eggs. You just want a baby. That's your endpoint. Third question, is there any way to improve motility? I'm assuming this is talking about sperm. So, again, difficult. It's very dangerous to comment in a specific way. A short answer, probably not. You want to complete a very thorough history and physical evaluation on the gentleman. Sometimes a urological evaluation is necessary. Typically, isolated motility issues are not correctable. There could be some exceptions if you had a severe infection or severe trauma. About 70 days prior, the sperm we have today, gentlemen, were made about 70-something days ago. Which brings me to an important point there. I wouldn't make any big decisions on a single semen analysis. Okay, you need 2 semen analysis. Remember that variability chart that I showed you, so that's part of the reason why. But talk to your doctor about that. But in short, motility issues, severe isolated motility issues of the sperm are usually not correctable. Okay. Fourth question, success story, azospermia. So somebody knows their stuff because they're using high-tech jargon here. I did not put that word in there. Azospermia means you have no sperm. Okay. So this is a gentleman who comes in, we do a semen analysis, we spin it down, we do a semen analysis, we don't see any sperm, then we spin it down, try to get a little pellet, we still don't see any sperm. First point here is it what we call obstructive or non-obstructive azospermia? Because this can be associated with cystic fibrosis, so you want to know what the volume of ejaculate is, okay? I'm getting a little specific, but it's a big point, and it speaks to whether this is a genetic issue or something else. So it depends is the answer on the cause. We certainly have the gentleman, or we have patients that we see, and they have no sperm, and we do a repeat semen analysis, and they have enough sperm for IVF. Okay, so there certainly are cases. We have patients who come into us. A lot of times the medical endocrinologist will put the gentleman on testosterone. Makes the gentleman feel a little bit better, a little bit buffer. It doesn't really make them buffer, but they have reasons for being on it. The problem is testosterone kills sperm. Not directly, but it's a negative feedback mechanism. So we can get those gentlemen to the urologist and take them off the sperm, put them on HCG. We actually give gentlemen HCG, believe it or not, and it works. And I have a patient who that happened to, and they got a baby right now. So there are definitely successes. It depends a lot on the clinical situation and the cause. So explore that with your doctor. 5 is a tough question. Is laparoscopy the best way to address endometriosis? So it really depends a lot on what you're trying to accomplish. If you are trying not to get pregnant, very different from if you are trying to get pregnant. Since this is an infertility talk, I'm just going to take the infertility aspect of it. Patients with mild or moderate endometriosis disease may benefit from laparoscopy. And it also may be beneficial to really find out if that's the cause of your infertility. We can't look at you and tell that you have endometriosis. Now, occasionally we'll see that you have a cyst on your ovary. That's a collection of endometriosis on the ovary. We call it endometrioma. Man, you can be pretty sure you have endometriosis if you see that, and that's kind of the exception. Otherwise, ultrasound may not be perfect for identifying endometriosis. Then you may want to have a laparoscopy. That helps us look inside. We can check the tubes, see how much endometriosis is there, and try to correct anything we see. However, improvements for fertility treatment with laparoscopy are quite small. So if you have infertility and it's related to endometriosis, you may have, there's several studies say 4 or 5 or 6% per month without surgery, okay? And remember, 15 is the max. I know 5 sounds terrible, but remember 15% is the ceiling. And you could have a laparoscopy, and in the literature, that'll improve your pregnancy rates by 2 or 3%, maybe 4%. Well, that doesn't sound like a lot, but if you go from 5 to 9%, that's huge. You almost, your doctor almost doubled your pregnancy rate. Okay, so that's one option, and a laparoscopy may be an option. Of course, you know what, guys? We don't know if you have severe disease or not until we look inside, usually. So I think laparoscopy is partially diagnostic and potentially therapeutic for fertility. And of course, we can treat that laparoscopy, we can treat that endometriosis aggressively and it can come back. I'm sure some of you know that, unfortunately. If you have severe endometriosis, probably your best chance is to consider, you just really want to consider IVF as your treatment of choice. Because it's going to take you from maybe 5, 6, 7, 8% to 50 or 60%. And that's a big difference. It's a 500% increase. I'm not saying you can't try pills. I'm not saying you can't do injectable medicines. But they don't effectively and directly treat the problem. Okay? 6, how big of a factor is age? I think we kind of covered that, so I won't hit on that anymore. It's just very, very significant. We know from genetic analysis of embryos that women in their 20s, egg donors, okay, about half of their embryos are abnormal. So these are women who don't have infertility. These are women that we recruit, not just us, anybody. That's 1 in 2 of those embryos are abnormal. So we are the antithesis of rabbits. We're very inefficient at reproduction. So that's what we face. And as you age, when you're in your 40s, early 40s, only about 11% or 1 in 10 embryos on day 3 are normal. And that's just a function of age. Probably some of you know that, for example, Down syndrome rates increase as you age. That's all the same phenomenon. You may know that miscarriage rates increase as you age. That all speaks to the genetics of the egg. And unfortunately, that's just it's not something that we can select embryos that are genetically normal with that PGD testing or genetic testing, but we can't reach in there and get the good eggs. We wish we could. That would solve our problems. Well, I'm going to close. I think I've got about 5. May I take 5 minutes of questions, or would you like to? Okay. I'll let you call on them.
Okay.
I'll take any questions you guys have. Yes, ma'am. Sorry.
No, go right ahead.
My husband has allergies right now, and I'm kind of concerned. Do the antihistamines do anything to his sperm count?
No. So the question was, and that brings up a good question. Do antihistamines harm sperm count? No. And I occasionally get gentlemen who are put on like Robitussin or those don't help either. Those cough medicines don't help the sperm either. So if you're on those, you can stop those and save those for dinner or a nice bottle of wine. That'll be more likely to get you pregnant.
But put on the cough medicine and try to get pregnant.
Correct. The idea is, I can't even speak to it, but the idea is it makes the sperm less thick. It's totally not true. Yes, somebody, yes ma'am.
Do you have one specific way that's best for women with PCOS?
Oh, short answer is no. Because every patient, okay, so the question was, do I have one best way for women with PCOS to get pregnant? Short answer is no, because each patient is individual. As you know, some women will respond to pills. So women with PCOS don't ovulate. So you just need to fix that. The question is, how do you fix that? Some women will respond to pills. For some women, weight loss, even 5% of their weight is a huge thing, and they'll start ovulating on their own and making me obsolete, which is great. So then they can it's a cheap way to get treated. So the first thing we always tell patients, diet and lifestyle modification. That may help you ovulate. There are medications like metformin, which may be useful. Again, that's an individual decision based on family history and perhaps whether or not you're insulin resistant. And you know, frankly, some patients don't respond to pills. These are PCOS patients really scare me to treat with injectable medicines because they're young. And they tend to just not do anything, and then their ovaries explode. And all of a sudden, you're on your way to a litter. So that's when we cancel. We try a different dose. But if things don't really work out, they're great IVF candidates as well because they tend to make a lot of eggs. I'm not saying you need IVF. A huge percentage of patients do well with pills and weight loss and just standard therapy. But that needs to be individualized to your specific situation. Yes. Yes, ma'am.
I've also heard that with the injectables, it can cause cysts. And if you're already prone to cysts, is that a good idea?
Well, injectables are designed to cause a cyst because they'll make you develop a follicle. Now, a follicle is a house for an egg, and it looks like a cyst. So, I don't think that would be contraindicated for you. But to add to that, clomiphene citrate or clomid can cause unwanted cysts. It sticks around in the body for a long time, so that can cause problems. And you just would want to know that if you were prone to cyst formations, that clomid might exacerbate that. Clomid's a great drug, but it just tends to hang around a long time. So
You're fine. You got
Good.
2 minutes.
oh, well, we have 1 minute.
Few
One
minutes.
more, 2 minutes.
I have a question about the differences between the percentages in success rates with IVF versus IVF with ICSI and cost difference.
Did you say ICSI? Yeah. Yeah, I'm going to repeat the question. So she asked about the differences in outcomes between IVF and IVF with ICSI. We didn't really talk about that, but if you have severe male factor, you don't have very many sperm at all, like maybe you have 20 instead of 20 million, We can fix that. That's curable. Prior to, say, 1990s, early 90s, it was, man, you were in trouble. But now, male factors, if we can get sperm from the testicles or we can get, we're good to go. So what she's talking about is placing a single sperm into the egg. And that's called ICSI, you don't need to remember that, or intracytoplasmic sperm injection. The outcomes, I would say that ICSI is a tool to be used in conjunction with IVF to facilitate pregnancy. So, sorry, I'm talking to you through the wall here, but bottom line is that not every patient needs sperm injection. And it improves outcomes in people who need it, but if you don't need it, it probably doesn't help you. Follow me? So, and most centers, ICSI's been around for a long time now, and people are very, very good at it. So talk it over with your doctor, whether or not that's indicated. It's always a bit of a challenge, especially if you have kind of a borderline semen analysis. So I think that it's time, right? Ladies and gentlemen, thank you for your attention.